directed distally 20-degree lateral views, and the oblique views 45 degrees in pronation and 45 degrees in supination.
May I ask a question? May I ask a question?
Yes.
Who really uses 6 views? I know that's written.
Actually, I think no one does, but these are the views which are mentioned in literature. But actually, I think that no one does 6 views for suspecting scaphoid, because it would be costly with high exposure to radiation. And if you will need 6 views to diagnose the fracture scaphoid, you'd rather do further investigation.
I think what Professor Nashat has pointed out now is extremely important. Not everything in the literature is true. Not everything in the literature is 100% accurate. And the practice of the doctor is what really dictates what you really need. I think the 4 views that Dr. Nashat has mentioned are more than enough. If the fracture is going to be apparent on a plain X-ray, these are the views that are really needed. You don't have to expand the cost or the effort for and the waste of course, the films now.
Dr. Mohammed, I want to ask you if after clinical examination, it was a suspected fracture scaphoid, but the plain X-ray were negative. Which approach which we go? Immediate further investigations, and what are these investigations? Or wait and casting for 2 weeks, then repeat the plain X-ray? Which approach you prefer?
Classically, what we were taught when we were young is that when you suspect a fracture of the scaphoid, which is not apparent on plain X-ray, then you put the patient in a scaphoid cast, and then you wait for 2 weeks, remove it, and have another X-ray. The fracture should be apparent at that time. This approach actually, I think, is too much of a fixation for patients who do not need that, and especially the professionals. When you are a professional and you need your hand as soon as possible, then you have to really evaluate the time wasted, the 2 weeks waiting time for just diagnosis, or you need other modalities, which we have nowadays that can prove this. Other modalities like MRI, technetium scan, ultrasonography, CT scan first, and then ultrasonography. If you need a specific way to really see a fracture, then a CT scan or MRI, I think, will be more appropriate. Technetium scan is too much for too little. You don't really need to see a hot spot. A hot spot can be seen in this case because of ligamentous strain.
Dr. Mohammed, I think you are muted. Dr. Mohammed, I think you are muted.
I'm sorry, it seems that I touched the pad by mistake. Which part was I lost? Since which part?
Further investigations. Which types of further
for the whole thing? Okay, I'm sorry for that. I was saying that CT scan, MRI are the best to go for diagnosis. If you need ultrasound, it will show soft tissue edema and other soft tissue, maybe a little bit, but technetium scan is a lot for little for this. So what for a professional
الكلام ده يا دكتور محمد بعد اسبوعين يا دكتور محمد الكلام ده بعد اسبوعين from waiting. انت بدات كلامك ان انت classical teaching you are going to wait for those fractures are not apparent in plain X-ray. بدات كلامك بهذا. ما انا عارف عشان كده عايزين نفهم بالنص ايه اللي حصل في الميوتنج ده.
Okay. Actually, classically, like I said, we were waiting for 2 weeks to show the fracture on plain X-ray. But now, if you have a professional who cannot really waste 2 weeks just to wait for diagnosis, then you have to go for further investigation. But if you have someone who can put 2 weeks aside from his work, from his life, and you don't have, or for the expenses or something like that, then you have to go classically. But usually, if you suspect a fractured scaphoid in a patient with normal plain X-ray, then you have to go for further investigation immediately. For us professionals, we cannot waste 2 weeks of our life just waiting for correct diagnosis.
Dr. Nashat, about further investigations which you recommend, ultrasound.
أحمد نعيم بعد إذنك يا رامي.
ايوه يا بيه، ايوه
دكتور احمد نعيم، ايه رايك في الكلام دوت؟
ايوه يا بيه والله. طيب اتفضل يا
دكتور احمد نعيم معانا؟ ايه رايك في الكلام دوت؟ انا لو انا عن نفسي بستنى اسبوعين، ايه رايك في الكلام دوت؟
This will bring us to the occult. This is the what we call the occult scaphoid fracture. I agree actually with Dr. Mohammed. If I have a professional patient, I prefer to proceed further in investigations like CT or MRI to pick up the fracture of the scaphoid. And because I think those patients will represent only 20% of the whole what we suspect having scaphoid fractures. The group of the suspected.
Then I will do five MRIs to get a one positive, Dr. Naeem. I'll do 5 MRI, each one costing 1,500 pounds, Egyptian pound, around, to make diagnosis of one, which can be later after 10 days can be clarified with another. Do you think this is sound in our country? وبرضه السؤال ده بساله
لا هو انا
للدكتور
بيتهيألي
ناش بعد اذنك تجاوبنا برضه من وجهه النظر بره يعني.
Dr. Amr, I think what Dr. Ahmed meant is that you are going to need these further investigations in one of each 5 suspected patients.
لا هو قال بيطلع من كل بيطلع 20% بوزيتيف في الحالات السسبكت. ده كلام دكتور احمد نعيم. طب هو يقول
لا أنا أعتقد يعني أنا what I meant that mostly the patients with negative MRI, negative X-rays and suspected scaphoid fractures, about 20% of them will be proved to have a fracture scaphoid. So in
زي ما قلت يا دكتور ماحي هو هيعمل الام ار اي عشان 20% هم اللي هيظهروا بوزيتيف.
Well, actually, what I prefer is to do CT in the professional.
أحمد عندك الصوت وحش.
I prefer to do CT.
لو أنت واي فاي اللي 4G يا أحمد.
حاضر يا بيه.
دكتور ناش رأيك إيه لغاية لما نعيم يرجع له بس الواي فاي بتاعه؟
I think you really raise an important issue.
ثواني يا أحمد. اتفضل يا فندم.
You raise an important issue, which is the cost involved, and it's not like here in America, we spend the money right and left, we do. But I totally agree. In a situation in which really the patient can wait and there is no rush and the patient's financial situation does not allow them to get a CT scan, I will go ahead and either put them in a rigid splint or a cast. The rigid splint is a custom-made splint, a thumb spica. It would be similar to a cast, but it's easier to take off if you need to. So there's no need to do a CT scan on every patient. So I think it's a matter of judgment call. If you feel that, as Dr. Mohammed said, if you have a professional, you have a surgeon, you have a musician, you have somebody who wants to know for sure, I think in those situations you can do the CT scan. But the whole idea, we have to exercise our clinical judgment with respect to everything related to the patient, their financial situation. Like if you are, for example, practicing in Kafr Shalamon and CT scan may not be close to you, I would really put the patient in a cast or a splint and wait, because really you have not lost anything. That the outcome will be the same. So you're not doing any disservice to the patient. Essentially, we are reducing the cost, and we explain to the patient that can do this or that. I would go ahead and wait for 2 weeks. It's not really a problem. So I definitely agree with you, Dr. Khairi, about that.
Yes, sir. اتفضل يا رامي.
رامي يا ريت بس تعرض لنا البلين اكس راي اللي هي فيها الفات باد ساين دي برضه كان ايد ان diagnosis. ايوه.
This is the plain X-ray. Yes, this is the plain X-ray of the patient. I think this is a magnified one. This longitudinal dark line is the altered scaphoid fat stripe sign. Unfortunately, this sign is only 50% sensitive and 50% specific, but it may aid in the diagnosis. Normally, the scaphoid stripe sign is a curve rather than a straight line with the convexity towards the scaphoid. In case of fracture scaphoid or intra-articular wrist injury, this the curve of the fracture is the curve of the line is reversed with the convex side with the concave side towards the scaphoid rather than the convex, or there may be partial or total obliteration of the space.
Okay, Rami, we talked about the CT and MRI and PET scan. What are the most sensitive and most specific of these investigations?
Actually, the most sensitive is the MRI, and the least most sensitive and specific is the MRI, and with the specificity reaching that of the CT, 98 versus 96%, while the ultrasound is the least sensitive and specific. Actually, this is an MRI. It's not of the scaphoid, it's of the tibia. It's a big bone, just to show you how the fracture would appear in the MRI. On the right, we have a T2 in which the cortical bone is white. The fracture line is the black line, and the surrounding bone edema is the grayish line or the hypointense line. In case of T2, the fracture line is also black, and the surrounding bone marrow edema or contusion is the white area. So in a small bone like the scaphoid, this faint black line may not appear, so the appearance of the fracture in the MRI may be difficult for non-experienced surgeons, non-experienced hand surgeons.
Actually, this is a very important point, Dr. Rami. I'm sorry for interruption, Dr. Nashat, but when you have such a view of white bone on T2 in the scaphoid, there might be a fracture non-displaced, or you may have bone edema. So you have to really know the diagnosis in this case, and you have to look further for if there is any other view that shows a fracture line or just a bone edema, and that's because the management here is quite different. Dr. Nashat, I interrupted you. I'm sorry.
No, thank you. I just want to say that if you're going to choose between the two, I will go with the CT scan for the following reasons. Number one, it's cheaper. Number two, you can see the cortical anatomy very well. So if you have a displaced fracture or angulated fracture, all these things will appear on the CT scan. I will use the MRI only if I want to assess the vascularity of the scaphoid or the proximal bone. That's really important. But other than that, I think the CT scan, you can really see everything clearly, and it's much easier. And also it will help you to plan what you're going to do with this patient.
One thing I would like to add, Professor Nashat Al-Hayya, if you are requesting a CT scan, the problem with the CT scan, it can be confusing because if you do not instruct or tell the doctor that you are looking for scaphoid fracture, they put the arm in the coil and the cuts will be just transverse to the scaphoid, and that may miss a scaphoid fracture. When you are examining scaphoid, you have to put the hand 45 degrees to the coil so that it will be along the axis of the scaphoid in order to show the fracture of the scaphoid really clear. If the doctor doesn't know that, if you're looking for scaphoid, you are going to get a transverse cuts in the scaphoid that might not show the fracture.
Thank you, Dr. Mohammed. That's an important point. Number one, I always send the patient with a diagnosis. I don't say
yes,
X-ray or MRI of the wrist, period. I give them a diagnosis. Number two, Dr. Mohammed raised an important point, which is essentially if you can establish a good relationship and rapport with a radiologist that you know, and he knows what you are trying to achieve, what you're trying to find, he will help you significantly. But your point is extremely important, Dr. Mohammed. Thank you for raising this. I appreciate that. But if you really go and give them a diagnosis, then they cannot come and say, oh, we didn't know. No, you have a diagnosis. Say questionable fracture of scaphoid, questionable fracture of trapezium. Give him a diagnosis. This way he will help you. If you help the radiologist, he will help you as well.
thank you.
Dr. Ahmed
Nash,
Naeem,
please, the last question. Dr. Nash, please, for the last, do I have any need to assess vascularity in a recent trauma in young chap?
No.
Or only in this is in the chronic cases? So
Exactly.
to solve the dilemma or to summarize, my tool now for the audience hearing us is a CT. Am I right, or I'm missing something?
Yes, sir. You're absolutely right. A CT scan is easier, it's faster, it's cheaper, and so forth. And for the vascularity, usually we don't really require that unless we are dealing with either Pricer's disease, which is avascular necrosis scaphoid, or non-united fracture with AVN. So I totally agree with you. In a acute condition, that part is not important. I agree.
Yes, sir. Yes, sir. Yes, sir.
Dr. Ahmed Naeem, if established confirmed fracture scaphoid after investigations, it confirmed with what's options of treatment?
Unmute يا نعيم.
Fracture?
Dr. Ahmed.
ايوه رامي. In such انا موجود.
Fracture scaphoid, undisplaced fracture scaphoid is confirmed and established diagnosis. What's the option of treatment?
The fracture in the waist or in the proximal pole? In the waist?
Yes.
Undisplaced, the fracture in the waist. Usually I'll put the patient in below elbow cast with extension to the thumb.
Don't prepare to do a percutaneous fixation for early return and decrease the time of immobilization?
In this case, I will do CT and I'll check if the fracture is complete or not. And where is the fracture exactly, in the waist or on the proximal pole? If the fracture is incomplete, or distal, I will proceed with just casting. If the fracture is complete in the waist, I will offer the patient, if he is a professional, I will offer him either one of two options, either to go with casting, or we can do percutaneous fixation. And I will explain to him the pros and cons of each of this method. And if he wants to return back to his work earlier and to discard the cast earlier, I think percutaneous fixation maybe will be more suitable for him. Otherwise, I will just put a cast for him.
About the type of cast, what's your preferred casting type? Above, below the elbow, Cooley's or scaphoid cast, and the wrist position?
For me, I will put him, I don't think that the above elbow cast will add benefits for non-displaced scaphoid fractures, although maybe historically there was a recommendation to put the patient in below elbow and above elbow cast to prevent pronation or supination, on the premise that these motions may be further displace the scaphoid. However, I think in the clinical studies, this assumption was not proved to have a different clinical behavior. Also, although the studies may show that not including including the thumb is not necessary for the patient, I usually prefer to put the patient in a thumb spica cast to not a coolest type cast. Maybe I feel safer with this with adding the thumb in the immobilization. Regarding the wrist flexion or extension, I think to put the wrist in neutral position is my preferred way of putting the scaphoid. One thing I want to add, maybe historically they prefer to put the patients in above elbow cast because there was no trend for surgical intervention. And I think this comparison nowadays, usually this maybe was above elbow cast was reserved to the unstable fractures, which nowadays we are proceeding with surgical fixation. And I think the issue of above or below elbow cast nowadays for non-displaced fractures, mostly they have the same prognosis.
Dr. Mohammed, would you go the same way as Dr. Naeem by counseling the patient to do a casting or percutaneous fixation, or you'll go through percutaneous fixation immediately?
Actually, Dr. Rami, I would like to hear Dr. Nashat about Nashat's opinion about this. But personally, I think that's why classifications are there. When you have an unstable fracture, then you have to know that the chance of non-union is very high in the scaphoid. But when you have a stable fracture, the chance of union is quite high. So the patient can be treated conservatively with a cast. And by the way, literature has shown that there is a great deal of scaphoid fractures can heal with just casting. The type of cast, there is dispute about it, but I prefer personally, like Dr. Ahmed said, the regular scaphoid below elbow cast. But the patient has to be compliant. He has to be aware that he is moving the fracture if he does move a lot, especially in rotation, especially if the cast becomes loose, then you have to change the cast. There has to be good fixation for these fractures. But if the fracture is unstable, then you have to really evaluate the fracture and then decide if you are going to do the primary fixation or you are going to wait for that. Dr. Nashat, I'd like to hear your opinion.
Thank you. I really would like to say to the people attending this, it's really a great pleasure to have people with such experience like Dr. Mahi or Professor Amr Khairi, because it's not just what's written in the publications, it's what you do in your own office. And what Dr. Mohammed said is extremely important. Number one, education is very critical. So when I see a patient with fractured scaphoid, the first thing I say is this fracture is a bad thing. It's a bad fracture. 20% of them will not heal no matter what we do. So the patient doesn't come back and say, oh my God, you didn't tell me, it did not heal, you did not do. So it's important to tell him, that's number one, 20% of them will not heal. Number two, it may take a long time to heal. Usually it heals within 3 months, it may take longer than that. Number three, there's a chance you may need surgery. That's at the beginning. Most of the patients, I treat them with casts, similar to what Dr. Mohammed said. I put a short arm cast, thumb spikes, like scaphoid cast. I don't do above elbows. And you'll find literature that supports anything. You'll find literature that says above elbow is better. You'll find, there was some literature recently, like 2 months ago, that says there is no need to include the thumb. So you will find something, but it's not just everything written. You go and immediately do it. You see what your experience means and the experience of other people in your department. That's why it's extremely critical that if you have something you are not sure of, you call Dr. Muhammad, you call Dr. Naeem, you call those people and say, what do you think? I'm not sure. If the fracture is comminuted or displaced, that's a different story, because then you're still, in the young people, you still can go with a cast. But there is a set of patients. Suppose the person who was injured is me or Dr. Muhammad al-Mahi. He's the one who broke his scaphoid. And he comes to you and you tell him, I'm going to put you in a cast for 3 months. So I'll have to close the clinic. I cannot do that. In the professionals, I just operated on a surgeon recently, about 2 weeks ago. A general surgeon, he fell. He had a non-displaced fracture. He's only 37. I put a percutaneous screw because he went back to work in 5 days. So in a situation like that, you say, it's not written in the books. No, it's written. We are physicians. That means you have to make judgment. You put all these things together and see what's the best for this particular patient. At the end, you make the decision. But in some patients, as I told the professionals, I had also a patient who was a cellist in a local symphony. I also put that percutaneous screw. But I don't do it for everyone. There is no need to do it for everyone. But in some patients, you may. But most of the time, I use cast immobilization, similar to what you have mentioned. Thank you, Dr. Muhammad. Thank you.
Thank you very much, Dr. Nashat.
Dr. Nashat, please, Dr. Muhammad, I want to ask you a small question coming to the basics. دايما اتعلمنا واحنا بنعمل سكافويد كاست نقول للعيان اكنك ماسك كرة تنس. نعيم mentioned that بيحطوا نيوترال. هل الكلاسيكال تيتشنج بتاع زمان يعني ليه سبيشال سيتويشنز بعملها، لكن احنا اتعلمنا ان انا دايما بنقول عندي شويه اكستنشن اكنك ماسك كرة تنس. فين الصح بالظبط يا دكتور ناشد بليز؟
Your response, Dr. Nashat.
Dr. Nashat.
Yeah, I think really it doesn't matter. They used to say you have to be at flexion or something. I put it in the comfortable position, which is really slight extension and a little bit of radial deviation. At the end, it does not make that much of a difference. Yes, so whatever you feel comfortable with, I think will be okay.
Okay.
Rami, say what literature tell about these things.
Actually, before going to the literature, I would like to have a question to our panelists. Do you have a cut-off point, anatomical point at which you classify the fracture as a waist fracture or a proximal pole fracture? Because this is a very common question from the juniors. At which point or level of the fracture would you consider this fracture to be a proximal pole fracture rather than a waist fracture?
Personally, I would consider the fracture is a proximal pole fracture if the scaphoid view and the oblique views show that the fracture is about 3 or 4 millimeters from the proximal pole. If you have it further than that, then it will be in the scaphoid waist. And if you look at the scaphoid bone itself, you'll find that the proximal pole actually is the part which has the attachment of the scapholonate ligaments and just a small piece after that, just distal to that. But then you have a big waist of the scaphoid through which the vascularity comes dorsally, or the articulation of the capitate medially. Dr. Nashat, is there something in the literature that would be put a line in that?
No. Again, you'll find everything, but no.
أنا يعني ممكن أقول هو الويست الحقيقة definition بتاع الويست this is a very difficult question. الويست في ناس some people define the waist as a line, the junction between the proximal and the distal articular surface, and others define the waist as an area rather than a line. But I think the best thing is that to define the proximal pole is the area proximal to the dorsal ridge of the scaphoid. This is the area between, if you have an X-ray, maybe I don't have a pointer or yeah, it is there is
not on this view.
Not on this. Maybe the ulnar deviation. Maybe Rami, can you bring back the ulnar deviation? Please, here the picture on the right side. Please, there is an apex on the lateral aspect of the scaphoid. This is the lateral apex. This is the lateral apex, and there is another one on the medial surface. This is the lateral surface. Yes. This is the lateral apex of the scaphoid, and on the medial surface, there is a dorsal apex. Between these two apices runs the dorsal ridge. Proximal to this line is the proximal pole. This is the proximal pole. Whether you define the waist as an area, this is the area distal to this line, or you define as a line, this is the line.
This line. You mean proximal to this line, not
proximal to this line is the proximal pole. The dorsal apex, where the attachment of the dorsal scapholunate ligament is attached. This is the attachment between these two lines is the proximal pole. What's proximal to this is the proximal pole. Whether you define the waist as a line or an area, it differs between the researchers.
Dr. Rami Diab, I think we are 47 minutes into this discussion.
Yes.
So if we are going
although
to
the basics are very important رامي بس لازم نجري شوية. انت عندك 5 حالات وعايزين نخلص 12. اتفضل.
ان شاء الله.
The results of conservative weather rather than surgical treatment is controversial, but actually in a paper which was published in The Lancet in 2020 under the name of Swift, it shows that there are no long-term results between difference in the results between conservative and surgical treatment. The paper saw that whether the thumb is included or not wouldn't affect the time to union or the rate of non-union. The position of the wrist, whether in 20-degree flexion or slight extension, doesn't affect the results. Like Dr. Naeem said, including the elbow or not is controversial with the literature, including only cadaveric studies showing that movement, that not including the wrist, the elbow in the cast will affect the healing rate, but the clinical studies are very rare, with only two papers published, one in 1975 and the other in about 1989. But these two papers show that including the elbow in the cast doesn't differ and doesn't increase the healing rate as compared to not including the elbow. The take-home messages.
Well, actually, Rami, this is what Dr. Nashat was saying. You'll find something in the literature saying everything. At the end of that, what you summarized now, perhaps you shouldn't put a patient in cast, but actually, yes. No, it's your clinical judgment.
Actually, this is published, and this is really published. This is really
published. I know. Like Dr. Nashat said, you'll find a lot of things are published. But would you put the patient above or below in a scaphoid cast or coolest type of cast? It's your experience and your judgment, and you are the one who is going to pay for it with the patient.
So ده اللي موجود بقى في الهوم مسج بي. ده اللي رامي هيقوله في الهوم مسج بي ان شاء الله.
The take-home messages are that the clinical scaphoid score of 4 or more is highly suggestive of fracture scaphoid even in presence of normal plain X-ray. MRI is the most sensitive and specific, including the thumb and wrist position doesn't affect the results of conservative management.
شكرا دكتور رامي وستوب شيرنج بليز. دكتور عمرو مصطفى.
السلام عليكم.
وعليكم السلام ورحمة الله وبركاته. اتفضل دكتور عمرو.
Okay. I will present just a case. This is a case of a 18 years old adolescent that was playing football, and then he has a trauma by the football, gutting his wrist in extension. Afterwards, he has a dull, deep pain in the wrist. and he is presented to me at the clinic with only these two views.
عمرو ممكن أسأل بس سؤال الأول بعد إذنك. Is this X-ray for a 10-year-old boy? Because the epiphyses of the distal radius and ulna are united.
Yeah.
So
he was 18. Yeah.
Is he older than that or 18?
He was 18. He was 18.
The epiphyses are closed.
Yeah, epiphyses
are closed. I'm very suspicious.
Normally, they close in the males between 12 up to 14, maybe extended plus or minus 1 or 2 years, and in females are below by 2 years. This one is 18 years old. Yeah, this is definite X-ray.
Dr. Nashat, are these X-ray views are sufficient for diagnosis of acute displaced fracture waist scaphoid, or do you need any further views or further investigations?
Normally, if you're going to present a fracture scaphoid, you present at least 3 views, preferably 4. So if somebody gives you 1 view or 2, that's not enough. You have to really show. This one, you can see the fracture. You see it's slightly angulated. There is a comminution, but there is also an area, I don't know if you can do that. There is an area here that looks like there is resorption. This doesn't look like it's a 2-week-old fracture. That looks like more than that. I don't know, but from the history, you can really take good information.
He was coming with, this was the first trauma for him, and it was dating just 2 weeks. Yeah. Yes. For me, it was, the views were sufficient because they show the fracture and show that it is displaced. This is why I didn't ask for further investigation. And even I have searched for, in the literature, this was published this year, 2020 in February, in the effort doing an open review for the guidelines for the diagnosis and treatment of acute scaphoid fractures. And they are stating that if after doing plain X-rays that you can see fracture line or they are not sufficient for the suspected case of a scaphoid, we do CT scan. But if they are sufficient, we are not in need. So this is why I didn't ask the patient for further investigation.
May I ask a question?
Yeah, sure.
When you go and send the patient for X-rays of scaphoid fractures, do you request certain views, or you just tell the radiologist, I need X-rays of the wrist? Do you specify?
Yeah, I specify, really. I specify.
So if the patient comes back with 2 views.
Yeah, but this patient came to me at the clinic with already diagnosed this scaphoid fracture with these 2 views. So this is why I didn't ask for further investigation. He didn't came at the ER, he came at the clinic.
If I may say something about that?
Yeah, sure.
Don't compromise. Do not compromise. If this scaphoid needs 4 views, get the 4 views. Why? Because you could see something else. You could see some combination of other things. So if you think when you said that this was enough, so I didn't ask him, no, it's enough with respect maybe, but you as a professor, you should not accept this as a final X-ray evaluation of scaphoid. No, it's not enough. I tell the patient, I'm sorry, we need to get the full views. That's my opinion.
Dr. Ahmed Naeem, as a case of acute displaced waist fracture scaphoid, how could you classify this fracture?
Actually, we have many classification systems. Maybe the most famous is HERBERT classification, and it's divided into 4 major groups. This is for the acute unstable fractures. This is I think B2 according to HERBERT's classification. This is the displaced mobile. This is displaced fracture of the waist. There are other classification. I think Rossi classification. This according to the orientation of the fracture, whether it is transverse or horizontal oblique or vertical oblique, according to the line of the fracture. And there are other classification, maybe Slade classification. This is based on arthroscopic classification or arthroscopic picture of the scaphoid. Mayo classification also, or what's called the Cooney or modified Cooney, Cooney's classification. There are different classification system, but the most famous is the HERBERT classification. For me, actually, I prefer to do CT or okay, maybe I to postpone this for further.
Okay, as options of treatment of this displaced fracture waist, as classic teaching, we do an open reduction and fixation through the Fowler approach. I want to ask Dr. Nashat, is there a rule for percutaneous fixation for displaced waist fracture?
Yes, there is. You can still reduce this fracture when you are doing the percutaneous fixation, because you really start with percutaneous fixation, and if you feel you are not able to get reduced, you can still resort to open. I was going to mention another thing about the X-rays, and please, Dr. Naeem, don't be upset with me. Here you don't have a lateral view. That's a must. Because how do you know that this scaphoid is not angled or whatever? You cannot have these two views and so this. I don't want the people who are attending to think that one oblique view and one PA and that's a sufficient X-ray for anything in orthopedics. It's not. And it's not only for scaphoid, it's for anything in orthopedics. Sorry. But as far as, yeah, I tried the percutaneous fixation, and if I can't get this to be reduced, but I think you can, I would do the open. Yes.
So if any case of a displaced fracture, you first you try to do it closed, yes?
Yes.
Okay. Dr. Amr, can you tell us what you did for these patients?
I will first continue. Normally, I use different classifications. Not only one classification is enough. First, the HERBERT classification, it classifies anatomical and state which is acute stable. But in the acute unstable, it states that complete waist fracture is unstable. And I am not accepting this. This is why I also include the Rosay classification in the type B2 classification of the HERBERT, because it states about the configuration, because some configuration at this one, which is the oblique vertical, is completely unstable one, but the other two may be stable and we can continue in cast. The third is the Cooney classification. The Cooney classification, if we apply on this fracture, as we could see there, that we have displacement that is more than 1 millimeter, we have even comminution, and also it talks about the interscaphoid angle, which should be less than 35 degrees in the PA view and less than 45 in lateral view. And in such cases, I think this
which we don't have in Amr.
Yeah, exactly.
The lateral,
exactly.
we don't have lateral view, that's why.
Yeah, sure. I will ask next time. But in such X-rays, I thought that there are many signs of instability. I have comminution. I have more than 1 millimeter displacement. For which case that I try to try it either open versus percutaneous. And as Professor Nash has stated that better to start with percutaneous fixation than an open. And really, when I have even searched the literature, this is a paper that is published even in 2020 that shows how percutaneous fixation for scaphoid fracture has a higher union rate, a higher return back to the rehabilitation rate, by other words. And the third is lesser complications. This is why if we have any displaced scaphoid fracture, it's better to try to do it percutaneous. But I have just a question to Professor Muhammad. What are the tips and tricks of closed reduction of a displaced scaphoid fracture and percutaneous spinning or percutaneous fixation, sorry?
Thank you very much for the question, Dr. Amble, and it's a very vital thing. Like any fracture in the body, if you do not have a correct anatomical reduction, do not accept closed reduction or percutaneous fixation, go for the open. Because fixing the scaphoid in a humpback deformity, or even in the recent case, like this case, you have comminution. This comminution, if you try to compress the scaphoid with the HERBERT screw, if it's slightly anterior and medial, then it will go into a humpback deformity. The change of the shape of the scaphoid, even if it unites, will cause a long-term biomechanical deficiency in the wrist joint, and this can result in chronic pain, radial side wrist pain, due to the union in the deformed position. So the tips and tricks, actually, you have to pull on the thumb, this will pull on the distal stump. You may even use like joystick with K-wires to help you reduce, and then temporarily reduce the scaphoid and fix it with a thin K-wire or even 2 K-wires before checking with X-ray. Once you are satisfied in different views of the wrist with the image intensifier that you have correct length and correct position of the fracture, then you can proceed for percutaneous fixation. You should not be happy that you have 1 K-wire in the scaphoid and it's in the near middle, and then we can fix it with a HERBERT screw and squeeze it, and then the scaphoid will end in malunion. You have to have correct anatomical reduction, and then you proceed for the fixation.
I have a question to Professor Nash. If you go to do percutaneous fixation for such a fracture, you do it from a volar or a dorsal approach, Dr. Nash?
Yeah, this one is a little bit in the distal part of the waist. If we're talking about defining the waist as an area, I would really go from the volar side. And that's really, sometimes that's easier to reduce the fracture this way. But also the literature says that lots of people have preference on dorsal side or volar side. I will tell everyone, if you're comfortable with an approach, use it. Because there's nothing wrong with doing it from the dorsal approach as well.
And you go, Dr. Nash, through the trapezium or through the volar aspect of the scaphoid?
I try to avoid doing anything for the trapezium, but if you have to, like for example, some people, their wrist is sort of stiff and you cannot get the trapezium outside the scaphoid, then you may have to go through the trapezium. It will be okay. But if I have a very mobile wrist, so it'll be easy for me. So if I have a fractured scaphoid, I will come to you guys and you can just put it, and you can go away from the trapezium. Yes.
Okay, thank you. In such case, we did
actually, Dr. Nashat, sometimes I do prefer just to extend my incision a little bit so that I can see the scaphotrapezial joint, open the capsule, have the K-wire fixing, not from the peripheral part, but a little bit inside the distal pole of the scaphoid in order to be really central in the scaphoid.
These are the tricks that you learn from a professional who has been doing this for a long time. Thank you, sir.
Yeah. Thank you.
Okay. So in such case, we go through an open approach, volar approach. And as you can see that we have reached the scaphoid fracture. And then we applied our guide wires as Dr. Nash has stated and Professor Mohammed have stated. In a hyperextension of the wrist, we try to go through the distal pole of the scaphoid. And after obtaining in a good alignment and with acceptable position of the K-wire, we have put another anti-rotation wire, and then we try to drill the scaphoid. And this, then we took a HERBERT screw with a lesser length than the normal by 4 millimeters to make free part 2 millimeter distal and 2 millimeter proximal to the HERBERT screw, or even more if it's possible, but so that the whole threads should not be passing through the fracture line to cause compression. Okay, so
if I may say, Dr. Amr, this is a very important point that you raised here. You don't have to have this, the HERBERT screw the whole length of the scaphoid. Once you have a waist fracture, then you have the smooth chunk of the screw in that area, and then you don't really have to have a very long screw. You are fixing very well with such a short screw. That's very important.
So as a take-home message, we should all stick to the indications for fixation, especially that for the cones, which is if we have a displacement more than 1 millimeters, or comminution, or about the interscaphoid angle if it is increased in the PA or lateral view. If it is possible to fix the fracture percutaneous, it is recommendable than doing it open. But if we don't obtain a good reduction, we have to open it as such a case. Because anatomical reduction is mandatory, because all the scaphoid is intra-articular, and so it is an intra-articular fracture. Screw length is very important, not to make it prominent, not to make chondrolysis of the scaphoid cartilage. So we have to at least decrease it by 4 millimeters or even more. Thank you.
Dr. Amr, I want to ask you a question. If you go back to the slide with where the screw, this is excellent. This is really excellent. And really, I would like you to tell the viewers why this is excellent. When you look at their own x-rays, how to really make that calculation that this is excellent reduction. So what are the criteria by which you can say that this is an excellent reduction?
First, it was an open reduction. So I can see it already intraoperatively. Especially, I put a human on the lateral aspect of the scaphoid, the broad, small one, because I think for me it is the most important thing in the reduction of the scaphoid, to obtain it at the waist, the broad one. Once you put it and you just make a compression from the thumb, you obtain a complete good compression of the scaphoid and a good alignment, and then you maintain your K-wire. So intraoperatively, I have obtained a good reduction, and then it's quite easy to insert the HERBERT screw in the central axis of the scaphoid.
Good job.
شكرا دكتور عمرو. وبعد كده الدكتور عبد الرحمن ضياء، يا ريت شير يور سكرين بعد اذنك.
Yeah, stop sharing.
Assalamu alaikum. It's an honor to be with you tonight, dear professors and dear colleagues. This case was a case of a male patient, 30 years old. He was a manual worker who presented to our center with a persistent pain in the non-dominant wrist for 1 year duration after fracture fixation.
في اكس رايز ثانيه او في ايمجنج ثانيه يا عبد الرحمن؟
لا، هي الاكس رايز والسي تي
كله. تمام. دكتور نشأت, how could you diagnose and follow up the union or non-union healing of the scaphoid fracture?
First of all, when you look at these x-rays, you know that this was going to fail. We just saw a previous x-ray and it was really, Dr. Amr, the reduction was perfect. And you could see that that fracture was going to heal nicely. But here, if you look at how this screw is not really going all the way to the proximal side, the x-rays are inadequate. You need more x-rays. Here you can see that how it's even protruding through the cortical side. And the scaphoid looks deformed. So really, I'm sure you have some other images. So to begin with, you know that this is really, this fracture is in trouble. And that's why I asked Dr. Amr to tell us how you really tell that this reduction is excellent. But if you finish your surgery and your x-ray looks like that, don't go home. It's not going to heal. How to evaluate the patient is still the same thing. Clinical examination, the level of tenderness that the patient has. And in those patients, especially if the union has been there for a while. I would like to get an MRI to just see how the vascularity of the proximal pole is. But usually between clinical evaluation and MRI, you don't need MRI in every patient, but if you are suspecting some AVN of the proximal pole, MRI would be very helpful.
في MRI يا عبد الرحمن للبيشنت ده؟
لا الحقيقة كان CTs available.
انا عارف ان العيان ده كان ريفيجن ان هو جالكم كان نون يونايتد اوريدي وكان معمول له بون جرافت وفولر فيكسيشن يعني. دكتور محمد, what's option of treatment according these X-rays and complaint?
This is what I was telling Dr. Amr about it. You have to reduce the fracture anatomically in order to get good union, but also your technique is extremely important. When you look at the lateral X-ray here, you can see that there is obliquity of the screw is not really anatomical. You are not holding the proximal pole or the proximal stump or proximal half of the scaphoid in a good way. So like Dr. Nashat said, when you have an X-ray like this at the end of the operation, this is doomed to failure. Then you have to really revise. What options do you have? You have to remove the screw, which is taking a lot of the bone stock that you have in the scaphoid here. And then you have to anatomically reduce the scaphoid back to its length and the degree of rotation. You can see in the CT scan that there is rotation between the proximal and the distal stumps. You have to reduce, you have to align the scaphoid in a good way, and then you have to think, how am I going to fix this? You have a lot of stock of the bone in the proximal stump, the distal stump, which is lost, and you have a proximal stump which is query. If it's vascular or not, it looks vascular, but you have to be sure about it. Of course, the intraoperative way. So, and also, don't forget that you are obliged by the first surgery of your approach. You cannot do multiple approaches for one surgery. This one was the line he approached from, and then I'm going beside it so that I don't go through the fibrotic part. No, you have to go through the previous scar if it's needed to revise. So I think you need to think about the type of fixation that you are going to have. Perhaps following reduction and the scaphoid, having a bone graft inside the passage of the screw, and then for the distal, for the proximal stump, you have to fix it well, and then perhaps using K-wires can be a way to resolve, or having a HERBERT screw through another inlet. That could be another choice that you have, but you have to decide that inside the operation, in the OR, and then you have to have the whole sets, the whole thing ready for use.
Dr. Naeem, can I ask you which type of graft would you prefer to use? Non-vascularized graft from the distal radius or from the iliac crest, or vascularized graft, either local or free?
In such a revision, I prefer to use a vascularized graft. Although maybe the literature does not support this or delineate the indication of vascularized graft in such revision, actually I consider this is logic to consider the use of vascularized grafts in such a case.
Would you prefer local or free graft, Dr. Ahmed?
Well, the decision I will, if actually I have to divide between maximum or massive defect with humpback deformity of the scaphoid. In this case, I will go or proceed with free vascularized graft from the femoral condyle. If I don't have a very big defect, or I don't have humpback deformity, I will consider the pedicled vascularized graft from the dorsum of the radius. This will be much easier. It doesn't provide you with a big amount of graft, and this will be suitable for the cases of proximal pole without humpback deformity or massive defect. In such a case, maybe I want to see another views to decide if there is a humpback deformity, but from the lateral view here on the X-ray, I don't think there is a big DZ deformity. So I don't think we need a very big amount of graft, and I think the dorsal vascularized graft will be sufficient.
Dr. Nashat, in your
Dr.
hand.
Naeem, Dr. Naeem, معلش, I think that you have a humpback deformity. Look at the lateral X-ray. The distal pole is 90 degrees. This is not an correct scaphoid angle. You have a humpback deformity, and it's also seen in the CT scan as well.
Yeah, yes, but this is minimal. Yes, this is a minimal deformity. And I think the need for the graft we don't need a big amount of grafting. And the lateral view supports my thinking, and that the leonate is not in DZ deformity. So I will expect there is a defect.
The leonate will not go into DZ deformity until late. When the leonate is central like this, does it mean that it is a normal situation? It might be that the ligaments are not attenuated enough to make the leonate go into a DZ or a VZ. Dr. Nashat, رأي حضرتك إيه معلش?
It's a very important part. Although the leonate in relationship to the radius, it looks like it's collinear. But if you look at the relationship between the leonate and the scaphoid and the scapholonate angle, you can really say that this is DZ. Because if you really put the scaphoid, can you see that? I don't know. If you look at this scaphoid, if you take this scaphoid and try to make it in the normal alignment, 45 degrees to this, to this radius, you'll find that immediately the leonate will go into the dorsal side. So there is a DZ in relationship to the scaphoid and the leonate, not the relationship to the distal radius. It doesn't matter. What matters here is that, number one, you need to get more X-rays to see it very well. Also look at better views or better sections of the CT scan. And if you really decide whether you do a local flag graft or a distant graft, that's really up to you. I personally don't do the distant flaps, call them flaps. I don't do the distal femoral condyle, but I prefer to do the distal radius, the pedicled vascularized graft, and I still can correct the humpback deformity even with that graft. Yes.
Dr. Nashat, in your hands, is there a difference between vascularized versus non-vascularized grafts in such cases with the absence of AVN?
For the last probably 15, 20 years, I've been doing all my bone grafts vascularized, all of them. And why? Because I said, well, if I'm going to really go ahead and put a graft, I might as well improve its chances of survival. Nothing more than that. It's not like I have to, but I feel like I'm just enhancing the chance that this non-union, we're talking about the non-united fractures. I feel like that this non-union, I probably may enhance this chance for this fracture to heal. I don't do the iliac crest in any way. I do not use iliac crest at all. The last time I used iliac crest for scaphoid was like 30 years ago. I always use distal radius if I use a free graft or a pedicled graft. Use free graft, not the scaphoid, like if you do intercarbal fusion. I use the distal radius for that, but it's not vascularized. But for scaphoid, I use vascularized all the time. It doesn't mean that you need to. I'm just saying that I like it. I feel like I'm just enhancing the opportunity. But again, there are lots of literature that says there is really no difference between vascularized and non-vascularized. And there are some other literature say the opposite. There is more vascularized, better chance for survival. So whatever you feel comfortable with, go ahead and do it.
Dr. Mohammed, I think
one question, Dr. Naeem. You have to remove the screw, right?
Yes, right, sir.
Okay, so you have to approach it volarly, right? In order to remove the screw. Then, if you are going to use a local dorsal bone graft vascularized, then you have to open from the dorsal part. Then you have anterior and posterior approach for the scaphoid, and this can result in decrease of the vascularity. So that's a question. When you have a case like this, I would be reluctant to go for the vascularized graft from the dorsal part. If I need a vascularized graft, then I will have to think about a local pronator flap or something like that. But actually, I don't think it would be easy to do an anterior and posterior approach for such case, especially with the humpback deformity and the removal of screw.
So, Dr. Mohammed, you prefer to go from volar approach for this case, yes?
Yes, I would remove the screw, correct the humpback deformity, restore the anatomical configuration of the scaphoid, put the bone graft vascularized or non-vascularized, and then fix.
Actually, I prefer the dorsal approach because I think through the dorsal approach, I can put my screw in a better way, perpendicular to the fracture site. And this is one,
How are you going to remove this screw first?
First from the volar,
yeah,
and then to adjust the screw. One of the problem of this, I think one of the reasons of the failure of this operation is putting the screw from the volar surface, because the purchase in the proximal pole is very minimal. And I don't think this screw conferred a considerable stability to the scaphoid. So I think putting the screw from the dorsal, from the proximal side, will allow me to be perpendicular to the fracture with a better purchase of the fracture. And as
let me understand this, Dr. Ahmed, Malish, I interrupt you. Are you going to say that you are putting all your screws from proximal to distal? This is a waist fracture. A waist fracture, classically, we go from distal to proximal, volar approach.
Yes, the classic in most of the types to put the screw from the volar. But there is a peculiar type of the waist fractures, which is the horizontal oblique. In some types of the fractures of the waist, the fracture line is a little bit oblique, and in this case, it's very difficult to put your screw perpendicular to the fracture. And maybe I think this is the scenario in this case in particular. But from this, please, as shown in the CT, if I put my my screw from the proximal part, I believe that I have a better purchase for in the scaphoid, and I will be perpendicular to the fracture, and this will allow me or give me a better stability. And because I will go from the dorsal side and remove the screw from the volar surface, from the volar side, and the operation was done from the volar side, this will add a benefit or makes the vascularized grafts I think more logic to use, because we may interrupt the blood supply, so we will be in need of some vascularized grafts.
دكتور احمد the attendees asked.
استنى النبي يا رامي، استنى يا رامي معلش بقى. دكتور نشأت please solve this dilemma, anterior or posterior, and please answer another question. I have done, I'm not a surgeon of course, but I have done many cases early in my life through the lateral bayonet approach. If it still has a place to solve this dilemma or what?
Yes, there is a place. Yeah, there is a place for all these exposures. Again, if you are really comfortable with a specific approach, use it. And none of us can say, oh, this approach does not work. If that approach works with you and your results are good, and at the end of the procedure, you look at your x-ray and you say, I am really happy with that fixation, go ahead and use it. But I don't think that you can say that, oh, you cannot do this through the dorsal or the volar or the mid-lateral. I think it's really whatever you feel comfortable with. Just the whole idea.
Sir, this is for an experienced surgeon, who have done many approaches. But I want you to speak to the young junior surgeons. Which approach in this case you will prefer?
I think if you are really going to, if you really have the humpback deformity and you want to correct it, then it will be better to go from the volar side if you're going to do the graft and you want to correct that. So for the simplest approach, you can do this from the volar side, because you can really open the site of the fracture that has the humpback deformity and put a wedge graft in that volar side of the graft after you open it, and that will correct the deformity very well. So the easiest way is the volar approach.
What about the difficulty? What about the Dr. Naeem's about difficulty to put the screw from the volar side? Is it true, or it's difficult in his hands?
It's not really. It's not more difficult than the dorsal side, because if you remember, all the approach for the HERBERT screw was from the volar side.
Yes.
So it's not going to be difficult at all. Really, it's equally difficult or equally easy.
Yes. Naeem, you have a comment, Naeem?
I think the alternative, or another alternative, all these options are maybe are valid. But if nowadays, if I go to, I decided to go from the volar approach, I will use volar plate. I think this will be better, but provided that the vascularity of the proximal pole is maintained. In this scenario, in this case, I will remove the screw and put my graft and put a volar plate rather than using the screw. If I want to go to add a screw, I prefer to use it from the proximal pole. This is my opinion. I may be mistaken or something, but this is my preference.
If you recall,
عبد الرحمن بيقدم عبد الرحمن هو اللي بيقدم الحالة، احنا نسيناه.
لا I want to ask a question, Dr. Mohammed. After removal of the screw, the space will be big space after removal of screw. Which type of fixation would you prefer to use from the volar approach, as you prefer in such a case? Would you put,
if I'm approaching this case,
would you put another screw, or what? Which type of fixation?
If I'm doing this case, actually, I'll open the volar through the volar approach, remove the screw, reduce the scaphoid, fix it temporarily with 2K wires, have X-rays, make sure that the reduction is good and the anatomical position is fine. Then I have to fill the gap in the proximal, in the distal stump, which is quite big. I have to put a bone graft inside. And if you look at the anatomy of the scaphoid here, I don't think that he left us a lot of space that we can put another screw through, because the head of this screw is Acufix is quite big and it's filling most of the distal stump. But then through the K-wire fixation that I have and put a pick of bone graft crossing the fracture, compress the fracture, and perhaps if there is a space, I would put a HERBERT screw, a 2.4 millimeter HERBERT screw through the anterior approach as well, in order to make further compression and aid in the union process.
اوكي عبد الرحمن اتفضل يا عبد الرحمن كمل بعد اذنك بقى ورينا عملت ايه في الحاله ديت.
You just need to remember that the scaphoid non-union is defined as the failure of the fracture to unite for 6 months or more after the primary injury. And revising the options of the grafts that can be used in such cases, we have two major groups, the non-vascularized group and the vascularized flabs. The non-vascularized are further subcategorized into cancellous bone grafts or corticocancellous bone grafts. Cancellous bone grafts from the radius or as part of the corticocancellous procedure from the iliac crest. The vascularized group are further subdivided into the local pedicle grafts or the free pedicle grafts. The local pedicle grafts from the distal radius are either from the dorsal part of the distal radius or the volar part. In this case, we have decided to go from the volar approach, remove the screw first, and then we have harvested a corticocancellous graft from the iliac crest using the Fisk-Fernandez technique in impacting the graft in the defect. Here is the graft harvested and the screw after its removal. Then we went dorsally using the 1-2 intercompartmental supraretinacular artery graft. This is the primary dissection, and then freeing the flap, move it to the fracture site. And then we fixed it using a headless HERBERT screw from the proximal to distal. This is the immediate post-operative X-ray. And after 9 months of the follow-up, complete union seen by the plain X-ray, confirmed by the CT at the fracture site, and no morbidity at the source or the donor graft. Reviewing the literature, the bone grafts available, we have, as we have stated, the non-vascularized graft first described by Mateus in 1960, excavating the space of the non-union and then putting the corticocancellous graft. Fisk-Fernandez has described an anterior wedge interpositional iliac crest corticocancellous graft. Comparing the non-vascularized bone grafts, either corticocancellous or cancellous, in unstable scaphoid non-union, in 2018, a paper by Kim et al. Has shown that the time to union was earlier in the cancellous group compared to the corticocancellous bone graft. Both has similar restoration for the scaphoid deformity and the rest function, knowing that both were fixed with screws, not only grafts. In a systematic review by Bender et al. In 2015, they reported their review for 1,600 patients regarding the union rates in the distal radius and the iliac crest, slightly better in the distal radius as a source of cancellous graft, but there were much morbidities with harvesting the iliac crest graft compared to the distal radius. There was no difference in the range of motion or the functional score. If we revise the fixation methods, using a screw have provided a slightly higher union rate compared to the K-wires, but those were much higher compared to using grafts only without fixation, in a 90 to 80%. the screws fixed fractures were allowed to mobilize earlier than the K-wire fixed fractures. The locally vascularized grafts, as we have said, are the dorsal grafts, 1, 2 intercompartmental supraretinacular artery, or 2 and 3 intercompartmental supraretinacular artery are the most famous grafts, 1, 2, and the 2, 3. The dorsal radius vascularized bone grafts actually cannot correct the humpback deformity, and this triggered the research for a volar-based graft to reach the waist fracture and allow support for the correction of the humpback deformity. If we compare
الرحمن ممكن نرجع للسلايد اللي قبل دهيا
دي ولا دي؟
اللي قبلها ايوه دهيا لا اللي قبليها. There is a very nice story that Dr. Nashat keeps on telling لا اللي بعد دهيا اللي هي فيها الرسمة بتاعت ال 1 2 super exactly. Okay. There is a very nice story that Dr. Nashat is always telling about this technique. Actually, the one surgeon who described this technique, as Dr. Nashat always said, is that this was a resident of orthopedics. This was not described by a professor. This was not described by even a registrar, a resident of orthopedics, who described this technique, which became extremely famous and very reliable technique after that. So
she's a female.
Yeah,
she's
actually,
a female also.
Female.
Actually, is a girl. Kylie,
Girl.
And she was a medical student, not even
medical student, not even resident.
And she became resident. She's a hand surgeon now.
Sheets.
Yeah.
She's called Sheets. Yeah. But she actually she's not describing. She conducted the anatomical study.
Yes,
the anatomical study about the vascularity and the distal radius. Yeah.
Which was the base for the technique.
Yeah.
Sorry عبد الرحمن للinterruption.
عبد الرحمن يا ريت go to الهوم مسج بعد اذنك.
May I ask Abdurrahman to return back to the post-operative X-ray, CT and X-ray? I'm sorry for interruption, but if because I think we have some useful. Yes. No, the CT, please. Yeah. This is what I meant by going from the dorsal side. From the dorsal side, our proximal screw will be perpendicular to the fracture line, and when we compare the lateral one, the picture or the photo on the right side and in the middle, the union of the vascularized graft on the dorsum is the vascularized graft is totally incorporated, while still the non-vascularized graft is not yet fully incorporated. This is the iliac crest graft in the space of the screw. It's not fully incorporated, while the vascularized graft and on the dorsal surface is fully incorporated. This may mean that the healing is maybe a little bit faster or better with the vascularized graft. This is what I want to point out.
Home message على طول عبد الرحمن بعد إذنك.
The take-home message is that the scaphoid non-union is diagnosed as non-union of the fracture for 6 months or more. The pedicled vascularized bone grafts are technically demanding. The indications for them are unsuccessful non-vascularized bone grafts in scaphoid non-union or a vascular necrosis of the proximal fragment. Pedicled vascularized grafts provide higher union rates in the proximal pool AVN. And the volar vascularized bone grafts are used for humpback deformity or the waist fracture. Free osteochondral vascularized bone grafts can be used in fragmented fractures. Thank you.
شكرا دكتور عبد الرحمن. ستوب شيرنج وتفضل دكتور حمدي. دكتور حمدي.
ايوه حاضر.
حمدي is our last case ولا ايه؟
لا يا بيه، في لسه دكتور خالد منيباري ان شاء الله.
اوكي اتفضل.
بسم الله الرحمن الرحيم. We present a case of a 51 years old carpenter, male patient who is right-handed. He gave a history of scaphoid fractures 3 years ago, which was treated conservatively in a scaphoid cast. Now he came to our clinic complaining of progressive radian and ulnar wrist pain, and he claims that it is affecting the quality of his work. And this is PA, lateral, and scaphoid view X-rays for his case. We, after reviewing these X-rays, we ordered an MRI. And these are the T1 and T2 stair views and cuts for the patient.
Dr. Mohammed, I want to ask about if you see any AVN avascular necrosis of the proximal pool, or what's your opinion about this MRI?
Actually, you can see that in the upper left views here, the T2 views, you can see that there is quite an edema affecting the distal part of the scaphoid as well as the proximal part, and even affecting the distal stump more than the proximal one. Of course, it shows the non-union, but it shows that there is vascularity of the proximal part is kind of doubtful, but there is bone edema of the distal stump and the T1 and in the T2 views here. You have to suspect bone edema in such a manual worker. I know that it's non-dominant hand, but he's a carpenter. He's using the hand, both sides, of course, regularly. And you can see also that there's quite synovitis and joint effusion in the wrist joint all around. So this is a case that has not to be confused with AVN.
Dr. Nash, do you think MRI sufficient for diagnosis of proximal pool vascularity, or do you use something else or some other types of MRI?
No, I use the MRI, especially with gadolinium. And
Yes.
Again, you really need to have a good radiologist working with you and can really show you. These images, it looks like there is a vascular necrosis, but it's not really clear. So it depends, because this one is like T2 and this one is T1. So it's not really clear because there are lots of edema. I think I would ask the radiologist. Again, it's important to have a good radiologist with you to help you, to guide you which way to go. But gadolinium is used frequently.
Dr. Nashat, you mean that there is AVN in the distal stump or in the proximal stump?
The proximal. But here's like edema everywhere. That's why I'm saying that you really need to see all the images to decide that. Yeah.
I think this is questionable. I consider this is questionable for AVN, maybe if in the vascular necrosis. But
correct.
Yeah.
It's not really clear. You're right. Yeah.
The only clear way to be really certain that there is AVN of the scaphoid is intraoperatively if you can see punctate bleeding. Dr. Hamdi, you tell us.
Okay, we do a better assessment for the non-union site and evaluation of the sclerosis, and for better planning for the surgical technique we are going to use. So from your point of view, what is the best technique we should use in this case?
Dr. Mohammed, options for treatment, please.
Well, this is a proximal pole fracture, and it's non-united definitely, and there are multiple of possibilities to do that. For a manual worker, and the point that would stop me here is that Dr. Hamdi, in his presentation at the beginning, he said that this patient is complaining of radial and ulnar side wrist pain. What the reason for the ulnar side wrist pain? We have to know. There is, of course, there is quite synovitis. There is quite an effusion in the whole wrist. But I think arthroscopic examination and perhaps arthroscopically assisted fixation of this fracture of the scaphoid can be beneficial, so that we can treat if there is a combined ulnar and radial reasons for the wrist pain, and also will help to fix such a fracture.
دكتور حمدي ورينا بقى عملت ايه في الحالة؟
So we chose to do a percutaneous fixation combined with arthroscopic debridement and grafting. We first do an indirect fixation to the scaphoid fracture by a temporary radiolunate wire to stabilize the proximal pole, and a distal scaphocapitate wire to stabilize the distal fragment and to maintain some stability during arthroscopic debridement and grafting. Also, there is another way to stabilize the fracture is to fix the scaphoid along its axis and debride and graft around the wires we are taking. Then we go to our arthroscopy. We put the patient on our traction tower. We started with a 3/4 intercompartmental portal to examine the radiocarpal joint to exclude if there is no radioscaphoid arthritis, no ligamentous injury, and to look at the TFCC. As Dr. Muhammad said, he has ulnar side wrist pain, and we found that it was nice and there is no injury. Then when we go to the ulnar mid-carpal portal, we used it as a viewing portal, and we designed the radial mid-carpal portal.
ممكن تتكلم من غير abbreviation، تقول بس للناس التي اف سي بالظبط ايه؟ triangular fiber cartilage.
Triangular fibrocartilaginous complex.
Okay.
And used the radial mid-carpal portal as our working portal. So we start by looking at the fracture site, identifying it, then probing it, use a small curette to debride it, then by using shavers, 2.5 millimeter or 3 millimeter shavers and bare to debride the fracture site, and see if there's any punctate bleeding in both fracture site in the distal and proximal fragments. Then we have multiple options for grafting. In our case, we used a small window in the iliac crest to obtain our cancellous graft. Also, there is a ready-made set for obtaining percutaneous graft. Unfortunately, we don't have it. Then we begin to impact our graft through a serum cover or the sheath of the bear we have used, then impacting it with a dissector. And this is a short video, 50-second video for what we have done in our case. We began to identify the site and open the fracture site with a curette. Then we began with debriding the proximal fragment with a bear, then going to the distal fragment. After good debridement, we used a wire to drill to see if there is any punctate bleeding, and this is punctate bleeding evident in our video. Then we, after obtaining our graft, we began impacting it in the fracture site.
Dr. Hamdi, I wanted to ask you here, how could you control your graft not to escape radially or radicarpal joint? How could you control the graft?
Okay. First of all, we have two types of fractures here. If the fracture is stable and there is a subchondral and cartilaginous support for our graft, we don't fear from graft migration. But if we are using our technique in unstable fractures and we are jeopardizing the volar and radial fibrous tissue during our debridement, PC Ho in Hong Kong and China used to describe a technique to introduce a 10 French Foley's catheter inside the radiocarpal joint and inflate it with a saline to block the radial side of the fracture, then beginning with grafting and finally using fibrin glue to maintain the graft in its side. In our institution, there is no fibrin glue, so we are very cautious not to deprive the boundaries of the fibrous tissue to maintain our graft inside the scaphoid if we use it in an unstable fracture.
As we see in the post-operative X-ray, you fix with the K-wires and you leave the scapho.
Yes, we remove the radiolunate wire. We remove the radiolunate wire and kept the scaphocapitate wire for better fixation, and added two additional wires along the axis of the scaphoid to maintain better stability. And we put our patient in a scaphoid cast for 7 weeks. And this is a follow-up CT done after 7 weeks. We can see crossing the bone crossing the fracture site in the coronal and the sagittal view. The CT wasn't done along the axis of the scaphoid, so some may notice there is a little humpback in the upper middle picture. I think the patient originally in the first X-rays didn't have any humpback. So why we chose this arthroscopic technique? First of all, it's less invasive. We can assess the fracture site better by the magnifying lens of the arthroscope. It's reproducible. If it failed, we could use it again and again, provided that there is no AVN. Also here we have an associated, we think of associated pathology, maybe a tear in the triangular fibrocartilaginous complex. So it's very useful when we are suspecting a concomitant pathology in the wrist. Also, it's one of the cases in our randomized controlled trial we are carrying now in Enchanted University Hospital. So what literature tells us about it? In this Lee et al. In 2016.
حمدي بعد اذنك حمدي قبل ما تخش على الليترشر احب اسال دكتور نشأت. دكتور حمدي showed us a marvelous technique, very good technique. But do you think there is other advantages over the open standard technique rather than examining the triangular fibrocartilage?
Thank you, sir. That's a very important question. I don't think we have the answers yet. Why? Because the number of cases that done arthroscopically is still relatively limited. And I personally I really don't have the skills to do it. I think it's really very good. I have to commend you for doing this arthroscopically. Time will tell. If it will be the only way to find out is to get lots of cases, follow them for a while, and then see if there is difference or not. But we have to welcome in a new technique, hoping that maybe this will help us in the future. After a while, we'll be able to compare them. But for now, we don't have the data to let us know.
Thank you, sir.
If you let me to answer the question here would be if this technique would benefit the patient from limiting the immobilization time and reduce the time for the patients to return faster to work. We know that ordinary grafting techniques are successful. So this is, I think, randomized controlled trials will answer this question. Okay,
what do you think fixation by K-wires is sufficient in such cases of non-union, which needs more and more stability?
I think literature in ordinary grafting techniques didn't show any difference in post-operative care for patients which were fixed with K-wires or scaphoid screw. I know that screw seems better for fixation, But here we use cancellous grafting. I think screw would compress the fracture side and would increase the humpback if we would prefer to maintain the length of the scaphoid.
هو الهامباك مش عشان السكرو ولا عشان ده هون يا حمدي. الهامباك because you did not really seek anatomical reduction في التكنيك الصعب ده هون. It's not a mandatory thing that you are going to get a humpback deformity, especially that we're talking about a proximal pole fracture. If you seek anatomical reduction before fixing the fracture, the final fixation, you will be able to avoid the humpback deformity.
Hamdi, can you tell us in which cases we should not do arthroscopic assisted technique?
Yes, it's better not to use this technique if we have heavy in a proximal pool. If we have a comminuted fracture, non-union pattern, it would result in a very large and huge defect, which is not wise to fill it with a cancellous graft. Also, when we have a severe humpback deformity, one of the troublesome for this technique to maintain the length of the scaphoid after releasing the traction. The distal fragment would rotate on the on the scaphocapitate wire and move into humpback again. So it's not the preferred technique in severe humpback. Better to use the volar approach and take a cortical cancellous graft. Also, when there is a oblique, very transverse oblique fracture reaching from proximal to distal, it's very difficult to reach a good debridement through all the fracture site. And if I am
معلش يا رامي بعد اذنك انا عايز اسال الشباب بتوعنا عمرو مصطفى او رامي سليمان ايه رايكم في الكلام دوت compared to open? Do you advise for this or you are still away from this? عمرو مصطفى كده لو موجود معانا يرد عليا. عمرو معانا؟ طب رامي.
Actually, I have no experience, but I think it looks like a glorious technique which will make you happy and will make you feel glorious during the surgery. But we need to see the results to see if it would be if the results would be better or not. And I think this is the core of Hamdi's thesis. So we are awaiting his results to know if it would give better results or not.
Dr. Amr Khairi.
رد سياسي.
Yeah, for me, Dr. Amr, I have done about 8 cases till now. I have
عمرو مصطفى معايا؟ اتفضل.
I have done about 8 cases till now. I have good results with the scaphoid waist, but the proximal pool, I really don't have.
8 arthroscopic cases.
Arthroscopic,
am I right? Yes.
I have did about 8 cases arthroscopically. I have union in all the waist fractures, but in the proximal pool, I have 50-50 percentage of union. And so I'm still revising myself to do it or not in proximal pool fractures.
عندك رد يا حمدي على الكلام بتاع عمرو دوت؟
Yes, يا دكتور عمرو بيه. Proximal pool fractures, non-union fracture proximal pools are one of the fractures that we are not sure about the vascularity of it. So if I am making an arthroscopic technique and found that the proximal pool is not viable, there is severe sclerosis and there is no punctate bleeding, it's not wise to complete our technique. It's wise to open the patient and do a vascularized graft.
Yes.
I think so.
Yes.
انما لو لقيتها vascularized وفي intraoperative punctate bleeding, you will
I think the patient يعني would benefit from the technique, and if he goes into non-union, he still has the chance to do vascularized grafting.
دكتور حمدي معلش لا أنا أعلق على دهين نقطة مهمة جدا. Guys, we have to know that avascular bone does unite. إذا كان عندك avascular bone and you put an avascular graft, they can unite بالnew vascularization that comes from outside. Vascularized bone graft usage here is more beneficial, of course, because you are adding more vascularity to the area. But avascular bone does unite. But mechanical fixation in avascular proximal pole fractures is extremely important. So K-wires here, like in this case, actually, it did unite in your case, Dr. Hamdi, but it would have been better if you have used one of the distally driven K-wires central in the wrist, in the scaphoid axis, and then you flex and you get it outside, and you could do a percutaneous proximal to distal HERBERT screw fixation. So actually, what you need to add to your technique here is mechanical stability as well, even if the proximal pole is avascular.
Okay.
Dr. Hamdi, تفضل.
After reviewing literature, we found no randomized controlled trials about this technique. We only found a retrospective comparative trial was done in Seoul, Korea by Untitled. He concluded in his comparative trial between arthroscopic and open grafting that both have the same union rate, near similar clinical outcome scores, and the same institutional cost. However, the arthroscopic group has increased operative time, better range of motion, but it was clinically but statistically insignificant. The correction of the scaphoid length and humpback deformity was more and better in the open group. So what's our take-home message? Arthroscopic grafting technique could be equal and less invasive alternative to open grafting in scaphoid non-unions. It demands a high learning curve, could be beneficial with associated wrist pathology, better to be used in non-comminuted non-union with no AVN in the proximal pole.
تسلم ايدك حمدي، شكرا. ستوب شيرنج بليز. ودكتور خالد منيباري اتفضل. بليز شير يور سكرين.
معلش الحالات ممتعه، احنا اسفين على الاودينس بتوعنا لو اخرناهم شويه، بس الحالات المناقشه الحقيقه يعني زي ما انتم شايفين بروفيشنال وممتعه جدا، بالذات في وجود الدكتور نشأت معانا والدكتور الماحي فالدكتور نعيم، فالحقيقه الوضع جميل يعني. فاخر حاله معلش استحملونا، واعتقد خالد مش هيكون سريع معانا. اتفضل يا خالد.
Okay, we'll talk about 22 years old male patient, right-handed non-smoker, the manual worker with a right side wrist pain, 1 year duration following fall on outstretched hand. The X-ray is showing a non-united fracture of the waist of the scaphoid, and here is the CT scan. There is humpback deformity, and there is no degenerative change or radiocarpal arthritis. Our decision in this patient, we are going to fixing it with a plate. We're using 1.5 mini plate, non-locked plate, using through a polar approach with corticocancellous bone graft from the distal radius. Those are the intraoperative imaging for the plate, and this is a semi-pronation view inflection and semi-supination for assessment of plate impingement over the volar rim of the distal radius. Also, we assess the impingement intraoperative through flexion and extension of the wrist to assess if there is any impingement of the plate over the volar rim of the scaphoid of the distal radius. This is the post-operative X-rays, and it is 1 year, 6 months follow-up.
خالد، هل ممكن نستخدمها في حالات الاكيوت ولا ملهاش رول في الاكيوت كيسز، كله بس في حالات النون يونيون؟
هو لما مبدئيا في reviewing the literature في يعني most of the paper are talking about using of this technique in the non-union of the waist fracture with a good union rate reaching about 100%. But also there is a paper by Mailing Ital in 2019. He used it in the delayed union and multi-fragmented fracture. So the most important indication for the plate fixation.
خالد معلش
معانا خالد شويه
اللي قبل كده شيل بس يعني شايف التايب اوف فيكسيشن هنا هون. It's first study has 6-hole scaphoid plate. The other one has 4 screw fixation. You fixed your fracture with only 1 screw proximal, 1 screw distal.
Yes.
This is against all fixation principles that we have for stable internal fixation. Why did it unite?
Please repeat the question.
Why did
المسامير قليله بالنسبه للبرنسبلز بتاعتنا يا خالد.
تمام.
فدكتور الماحي بيسالك كان كفايه مسمار ومسمار ولا انت شايف المسج بتاعتك؟
Intraoperative, it was enough. We tested the intraoperative, the motion of the fracture, and the flexion and extension, and the fracture was stable. And actually, this plate is not.
معلش استنى يا خالد عليا كده، معلش انا احب اسال هنا بقى دكتور نشأت. انا يعني مش بهاجم خالد، بس انا شايف ان دوت اوفر دوينج فور ذا هول ماتر. دكتور نشأت plating has a role in fracture. معلش انا بتكلم بصوت العامه مش بصوت البروفيشنالز زيكم. فدكتور نشأت do you think there is a role for plating مع مخاطر الامبنجمنت ومخاطر ان ما اقدرش احط اكتر من سكرو زي ما خالد كده يعني والجوبردايز ماي فيكسيشن؟ فحضرتك رايك ايه في الموضوع ده كله؟
I think it is nice to explore other methods or new methods, but again, you really stick with what you feel comfortable with. I personally don't use plates. I'm comfortable with what I do, but you know, when we do something new that allows us to expand our horizon and see other methods, maybe it will prove at the end it will be a superior method, but we don't know that yet. So as of now, it's very rarely used, but it's still another method. And that shows the audience also, there are so many variations of how to fix a scaphoid. So there is no one simple solution for everything. Again, you go back to from your experience or experience of your professors, you really tell which one is the most convenient for you. I personally have never used plates, but I see some people have good results. More power to them, but that will not be my approach.
دكتور نشأت معلش انا اسف يا دكتور عمرو، طبعا برضو انا هيريبيت الكويستشن بتاع الدكتور عمرو بانذر واي. يعني دكتور عمرو يقصد بايو ميكانيكالي لو انا حطيت مسمار ومسمار ده ضد البرنسبلز اوف فيكسيشن، بغض النظر عن ان احنا يعني ده نيو واي ونوفل واي اوف فيكسيشن او ديفرنت موداليتي اوف فيكسيشن، ده ضد البرنسبلز بتاعت الفيكسيشن احط مسمار ومسمار، هل ده sufficient بايو ميكانيكالي؟
Normally no, I would say no, and but he said it was really solid when he was doing it. But again, we have to rely on the basic principles because those principles have been proven time and time again to be accurate. So I would feel more comfortable if we have more fixations based on the general principles of internal fixation.
يعني الشريحه اللي قدامنا ديت يا خالد فيها 6 مسامير.
مش
اللي انت عارضها
تمام.
الموديل اللي انت عارضه
دي اللي هي ميد ارتس، 1.5 اللي هي ترايلوك. دي مش افيلابل، يعني احنا دي مش افيلابل
دي مش موجوده عندنا هنا يا بيه. دي شريحه ترايلوك بتاعت
anyway مش بكلم عندنا، قصدي هو ده السوتابل يعني عشان اقول ان انا عامل فيكسيشن مش هستعمل كاستنج وهستفيد بفوائد الفيكسيشن، والا يبقى عملت كاست يبقى عملت زي الكواير. فاهم قصدي؟ ده اللي الدكتور المحي كان قصده في كلامه. يعني ان اعمل مسمار ومسمار واقول له حرك، اتس ا فيري ريسك، هاي ريسك. يعني يا جماعه جايز انت كانت حاله كويسه حظك كويس وكان المسامير ماسكه كويس، لكن في حاله ثانيه ممكن تبقى تلاقيها في حجرك بعد 2-3. فده بس ده كان كلام الدكتور المحي يعني. اتفضل كمل. طيب
what I meant دكتور خالد, you have always to explore زي ما الدكتور نشأت بيقول. That's the idea about innovation. You have to think out of the box and you have to apply what's new in every way. But there are principles that we have to stick to. واحنا في الويبينار ده هو احنا we are giving message للي بيسمعونا. We have to be careful في المسج اللي احنا بنديها لهم، مش ان لو استخدمت مسمار ومسمار في tibial fracture بعد كده هو هيونايت. لا، there are principles that we have to stick to. سؤالي ليك هي لحمت ليه؟ رأيي أنا لأنك حطيت بون جرافت كويس، لأن البليت اللي أنت حطيته ده هو رغم إنه هو one screw إنما كان solid enough. It's a locked screw, right?
لا non-locked screw.
non-locking كمان، يعني it was non-locking بس كان ثابت. بس this has to be supported by external immobilization for the whole period of your fixation لغايه ما يحصل اليونيون.
عملت external immobilization يا خالد؟
عملت يا خالد معاك البيشنت عامل موبيلايزيشن على طول، يعني هو ما كانش فيه موبيلايزيشن بس كان جاست 1 ويك جاست عملنا ريموفال للسوتشر والبيشنت كان فيه موبيلايزيشن على طول.
ده بيجينرز لاك يا خالد. ده بيجينرز لاك، لكن انا ما اقدرش ده اقدر اسميه تحت كلمه violation of principles. ما اقدرش ان انا اقول مسج للناس حطوا مسمار ومسمار under any circumstance. لو ما عنديش البليت الستة هول يبقى I think I have to search for another way of fixation. اوكي كمل الانديكيشن بتاعتك.
يعني انا بس may I comment يعني هو طبعا completely right. Unfortunately, the typical plate is not available. But we also see sometimes, or in many times, the scaphoid non-union unite with just K wires.
على فكرة أنا شفت البليت ده عند أحد الشركات يا دكتور نعيم. مش عايز أقول اسمها يعني عشان بس ما نشيعلهاش، لكن أنا أعتقد إن أنا شفت هذا السكافويد بليت ال6 هولز دوت عند أحد الشركات في مصر. بقول لك عليها بعد الويبينار.
هتقولنا في الاسم بقى يا دكتور عمرو لو سمحت.
عينيا بكره تكون عندك ما تقلقش.
احنا اوريدي بكره دلوقتي. احنا اوريدي
عارف السكه بقى.
خلاص النهارده يا بيه، النهارده حسبت السكه.
صباح الفل.
صباح الجمال. كمل يا حمد، كمل يا خالد اتفضل.
هو الموست important indication for plate هو non-union. The plate provide greater stability and prevent extrusion of the corticocancellous wedge graft. Also, it's important to use it in the acute comminuted fracture and oblique fracture and the complex wrist injury.
انت حطيت يا خالد الشريحه دورسال ولا فولر ولا
هو most of the papers of the literature are talking about using the plate volar to act as a buttress, but one study reporting using it as a dorsal to act as a tension band during wrist mobilization and achieve dynamic compression, but it will need an intact non-comminuted volar cortex.
عمرو مصطفى استعملت شريحه زي كده يا عمرو؟
لا يا بيه ابدا، لا ما
حصلش. ولا رامي طبعا.
لا يا بيه، لا يا بيه، لان الاناتوميكال بليتس مش موجوده في مصر للاسف.
ايوه طيب اوكي.
لما الدكتور عمرو قال لك يا ابني هيجيبها لك بكره الصبح، عايز ايه؟
اول لسته هتلاقي 5 شرايح عندك يا رامي ما تقلقش.
100
قول لنا بقى according للليتريتشر يا خالد comparison بين الديفرنت ways of fixation سواء مسمار او اتنين او شريحه.
هو يعني available، يعني ما فيش، يعني there is no available in the literature mechanical studies, but the biomechanical study comparing the screw and the plates and the screw with a screw, one screw and double screw and the plates. Double screws or plate fixation demonstrated significantly greater stability and stiffness and energy absorption when compared to the single compression screw, especially in osteoporotic wound, but there is no difference between double screw fixation and the blade groups. The take-home message for
قول لنا معلش الاول، قول لنا ايه مشاكل الشريحه دي، يعني ايه الكومبليكيشنز اللي ممكن تحصل منها؟ يعني
هي المين كومبليكيشن ريبورتد في التريتشر هي الامبنجمنتس. الامبنجمنت من البيشنت دايما there is need for removing the plate.
يعني دايما العيان بيحتاج يشيل الشريحه حتى لو انت انتر اوبراتيف اتاكدت بالفيوز والفليكشن والاكستنشن فيو مع الاكستنشن واكستنشن، وان ما فيش اي امبنجمنت على الفولر ريم بتاع الديستال راديوس.
وايفن لو انا ما فيش امبنجمنتس انتر اوبراتيف، some patient reporting pain post operative pain with a follow up which improved after removing the plate.
يعني انت كده بتحتاج تشيل الشريحه برضه.
Yes.
تمام. اتفضل يا خالد.
The take-home message using a blade fixation as a buttress or as a tension band is a valuable option in case of comminuted or non-united fracture scaphoid. Intraoperative assessment for presence of impingement over the volar rim of the radius needed. The need for blade removal is one of the drawbacks of the blade fixation. proximal pool fracture is not suitable for plate fixation, and the further randomized trial needed to confirm the best method of fixation.
شكرا يا خالد.
Thank you.
بس ليا كومنت سريع بس يعني I don't think انها يعني it's a must to remove the plate. هو في reported indication يعني او في incidence كده I think about 20%, لكن not on all cases يا خالد. Need for removal maybe 20% that's reported in the literature. لكن هي it's still a problem. With 20%, this is a considerable number.
At the end, we want to thanks.
At the end احنا بنشكر الناس اللي سهرناها، و at the end احنا بنشكر المودريتور بتاعنا الدكتور رامي دياب اللي كان اول مره مودريتور بس اداره كمودريتور محترف. و at the end برضو بنشكر البانل بتاعتنا الدكتور الماحي العظيم والدكتور احمد نعيم الاورجنايزر لكل هذه الايفنتات بتاعت الهاند. و at the end نشكر السبيكرز بتوعنا الدكتور عمرو مصطفى، الجان بتاعنا الدكتور رامي سليمان، الدكتور عبد الرحمن ضياء، الدكتور خالد منيباري، واخيرا الدكتور حمدي النجار. و at the end طبعا لازم هنشكر the government of the American College of Surgeons, the current president of the American Association of Hand Surgery, the past president of the American Society of Peripheral Nerves العظيم الكريم الدكتور نشأت نعام اللي دايما بيشرفنا ودايما بيكون لنا الشرف ان احنا بنستضيفه عندنا، وانترناشونال فيجر عظيم الشأن، عين شمس جرادويت، نحترمه ونقدره ونشكره على حضوره. اتفضل يا فندم.
دكتور عمرو واحب اضيف ان الدكتور نشأت هو الاونرري بريزيدنت فور لايف for the Egyptian Society for Surgery of the Hand and Microsurgery as well.
يعني بيه هو ناقص تايتلز يا بيه، خلينا التايتل دوت العب بيه شويه ولا حاجه، يعني هو ناقص تايتلز يا بيه، يبقى نضيف طبعا تايتل، وده شرف لجمعيه جراحه اليد المصريه طبعا.
ربنا يخليكم. Thank you so much.
In recognition for all what Dr. Nashat meant to us and meant to everyone interested in hand surgery in Egypt الحقيقة.
Thank you.
طبعا يعني دكتور نشأت في حد ذاته هو سكول اوف هاند سيرجري، وبنشكره على تواجده معانا وعلى الوقت اللي بيمنحه لنا. انا بشكركم جميعا وبشكر الاودينس اللي تسهروا معانا جدا. بوعدكم ان شاء الله الجمعه. اتفضل.
بدون مقاطعه بيه، بس يعني بفكر الاتنديز كلهم يعني بدعواتهم للدكتور رفيق مره ثانيه معلش.
لا اكيد انا مش هنساها برضو. والاسبوع الجاي ان شاء الله لو ربنا ادانا العمر ويكون الدكتور رفيق وسطنا برضو، هنتكلم مع تيم التروما الجميل بتاعنا على البروكسيمال هيومرال فراكشرز في الويبينار ال 24 بتاعنا ان شاء الله. هيبقى تيم كويس قوي، في ناس، في ضيوف من قصر العيني، في موضوع انترستينج، موضوع فيه ديبيت كتير وفي حاجات كتيره جديده ان شاء الله تكونوا معانا باذن الله. ونشكركم وتصبحوا على خير، وجزيل الشكر للبانل والسبيكرز والمودريتور، وتصبحوا على خير، وعين شمس دايما دايما في انتظاركم، ودايما هتكون القبلة العلمية ليكم. اتفضلوا. شكرا لكم.
Thank you very much.
Thank you sir. Thank you sir.
Thank you. Thank you. I appreciate it.
شكرا دكتور عمرو.
Thanks.
شكرا يا بيه. شاكرين للسبيكرز، شاكرين جميعا. شكرا.